In this video, we'll cover the most important causes of shoulder pain, and to differentiate the cause of shoulder pain, we have to think what the question is pointing us toward. So, is the range of motion, which type of range of motion is affected? Is it active motion? Is it passive motion? Or are both affected? Then, are there any particular examination findings? Is there any tenderness anywhere? Are there any positive physical examination tests? What movements are affected? Is there pain with abduction, external rotation, internal rotation, flexion? So, all of these can help us to narrow down our differentials. So, the first differential we're going to talk about is rotator cuff impingement or tendinopathy, in which there's pain with abduction and external rotation. So, on examination, there might be subacromial tenderness as well. And the passive range of motion is usually normal, and active range of motion is affected. So, there are some physical examination tests that are called impingement tests, and in rotator cuff impingement, these impingement tests are positive. So, these are called the Neer and Hawkins test. So, in the Neer's test, what happens is that there's passive forward flexion of the internally rotated arm, and if there's pain, then that indicates impingement. And in the Hawkins test, the arm is flexed to 90 degrees, the elbow is flexed, and there's forced internal rotation of the arm. So if there's pain, then all that also indicates there is rotator cuff impingement. So that's it for rotator cuff impingement or tendinopathy. Then we have rotator cuff tear. This is similar to its presentation is similar to that of tendinopathy, but in this the question will hint more towards weakness than pain, and there is weakness with abduction and external rotation, just like in tendinopathy. And often the age of the patient is more than 40 years of age. Then we have adhesive capsulitis, which is also known as frozen shoulder in the common language. And this is more gradual in onset, and there's more stiffness and pain over here. There is decreased active and passive range of motion. So there's especially abduction and external rotation are more likely to be affected, and sometimes there are certain risk factors that are present. Sometimes the question stem will mention a diabetic patient, or it might even happen after immobilization of the shoulder joint. Then we have biceps tendinopathy or rupture. In biceps tendinopathy, this is more like anterior shoulder pain, which worsens with lifting objects, carrying, or overhead reaching. And sometimes, in biceps rupture, what happens is that there is a sudden pain, and there is a visible Popeye sign that you can see in this picture over here, and that's for biceps tendinopathy or rupture. Then we have AC joint sprain. In this the pain is localized over the AC joint and the acromioclavicular joint, and there is pain with passive shoulder abduction. And also the question stem will mention that there is a history of fall onto the shoulder as well. Then we have the glenohumeral osteoarthritis as our next differential. And in this is more uncommon, and usually there is again a history of trauma. And in this, the onset of the pain is more gradual. There is anterior and deep shoulder pain, and active and passive range of motion are affected. So Abduction and external rotation are again affected.